Welcome. We did not know coming into this, and I wish I had a little bit better. I used some white text on lighter backgrounds in some cases, and I noticed that some of the slides with normal darker text don't seem to show up very well, so we'll guide you through this. I'm glad you're all here, and I've heard a lot of people say, well, are you going to talk about right to repair? Of course. We're going to talk about three areas, really. If you read the brochure, we're going to talk about three areas and how they might play against each other, but how they are kind of this perfect storm, as I'll say, in HTM. This is just the cover slide, and I don't know if she mentioned it, but slides will be available, in a couple weeks maybe, and the recorded presentation. I am going to give to MD Expo the links in my presenter's notes. Sometimes I will put some valuable notes for me of where I sourced some of the information. I'll give that to them so that you also can get that if you download it from their website. So today I mentioned that we're going to talk about three areas and really about how HTM professionals can have a little bit more empowerment, right? Empowering your voice. Whether or not you're in an organization that, say, you figure nobody listens to you, right? You're a third party and they just say, okay, come in and fix something, and then you're done, right? And they discount you. They might know you. Like, I see some very familiar faces here, like David. He's awesome in many, many ways, at least I hope still. I had a privilege to work with him. And his customers knew him very well because he was great at delivering service. I don't know what you're doing today, but if you're a service manager or whatever, hopefully that's the same thing. But HTM's voice sometimes varies from institution to institution. For most of you, you probably already know this, right? Most of you I recognize as either being in HTM or used to be more in HTM and are on the supply chain side. Is there anybody else kind of in this audience that I don't feel like I've represented well? I see third parties, in-house, vendors of some type. Robert, vacation travels and stuff like that. Where do you?
Joe, I'm a vendor. We manufacture batteries for use.
Okay, so parts vendors, is that? Okay. Just to make sure I kind of know the audience a little bit. Yeah. So hopefully I can see them at my angle a little bit, and it surprises me because my eyesight's not as good as it used to be, and it keeps declining. But this is our roadmap for today. We will cover the following areas, kind of where we are right now. We're at a crossroads. We're always at a crossroads. I would tell you that things are going to evolve. Cybersecurity came up, and that was at a crossroads, right? Even though maybe it shouldn't have been. Things that we've talked about for years and years, like right to repair or professional licensing or certification, are the things that we'll talk about today. So we're at a crossroads. We are going to kind of, at the end of this, we're going to do something a little unique. And I'm going to have you work through just a very simple action plan about things that you might be able to do to empower yourself and empower the HTM community. So I like this a little bit, but HTM is kind of where reality meets innovation. Sometimes I wouldn't say jury rig or we create solutions, right? They may be technical solutions, they may be a bridge between technical and clinical, but we certainly play a huge role in healthcare. The best numbers I could get, like I said, I'll provide these links to MD Publishing, is there are approximately 12,000 HTM professionals. This is those people that work in a hospital setting, at least occasionally. They might go to that hospital occasionally and then go to another hospital. They may work at a surgical center. But there are about 12,000 professionals estimated to be in the US today. This does not, I however believe, take into account a key area that sometimes is forgotten about that I think is HTM professionals, and that's the depot level technicians that may work for, say, an Avante or whatever, and perform a service off-site. Does that make sense?
Does that include OEMs, Dustin?
This does, but from the multi-vendor, from what I gather. This does not take into account those field engineers that are directly a OEM servicing only OEM equipment, their equipment. And we'll talk about that a little bit in right to repair about, you know, you've heard all this probably in the past, but there is a distinction. Just because you say wear a particular manufacturer's shirt and you're working on, say, some other manufacturer's equipment, does that not take you into the realm of being an HTM professional or more of a multi-vendor ISO or whatever you want to call it, right? There's clever names out there. So we represent a very small group of people. This is the laser pointer works. The laser pointer shows up much better. But 12,000 professionals in the US, about a 600 billion global medical device market globally. I couldn't get that number necessarily to match with the US.
Is that medical device sales or service?
Medical device sales. Sorry, yeah, not service. If this is service, we should all be running our own companies and turning the wrench at the same time. But we don't see a lot of this revenue. We support a lot of this, so it's not a wasted investment. And then I found this kind of interesting, but this 35%, I don't think this is actually true. 35%, if you look around the room, I know that some of you are certified, some of you even teach certifications or study courses, but this number seems very, very high, that 1 in 3 people are. Colorado even being one of the highest percentages, yes. Yeah, so I
Out of 12,000, there's 5%.
Yeah.
Doubtful.
Yeah, I've never worked in an organization with more than maybe 50% of the staff. I know there are a couple of shops out there that have fully been certified, but that's the high, right? Was that
like two-person shops?
The two-person shops, maybe. Yeah, there might be a third person that comes in and that blows their numbers, but anyway. So I mentioned that we're kind of at this perfect storm area, I believe. And right to repair is one of the elements. How we service things, or how the access that we have to service things. What our profession is, and I'm going to talk about a little bit about that from the licensing perspective, and how we establish competency of professionals. And I'm going to talk about certification. There are much larger discussions that can be had on all this. And I know some of these are controversial. So for those of you that aren't, say, certified or let your certification lapse, there's a reason, right? And those reasons might be because you don't see the value in some of the certifications that are out there. But I'm going to talk a little bit about that later on. This is primarily from USPIRG. This data, this is post-pandemic data primarily, but about 80% of us, and I was probably one of the respondents on this, said that we had some sort of restriction to perform service on something that we thought, at least, we should be able to service in our healthcare setting or for our customers if we were a third party, right? Those respondents also said that it caused a delay. It may have caused a delay, and I remember filling out a couple of these surveys. If you have not, fill them out. It gives better data. But in filling out these surveys, at least one of them, I could only think of a few instances where I knew it impacted or caused a delay in patient care, but it definitely has in my experience. So 70% seems like a pretty reasonable number. 90% surveyed said that there was a need of us. When I say us, I am in a slightly different role, but it's hard for me to ever say. In my heart of hearts, I started as a technician. I still have some of that in my blood. And you ask my wife, I like to try and keep things alive at my house. Half the time she wants to say, buy a new washer, dryer. I want to fix it. But 90% of us said that we needed something to help us bridge that gap, right, to repair. And rural hospitals, I had the opportunity to really serve the rural hospital market myself, much more than I ever had in my career in the last couple of years. Rural hospitals experience this over and over and over again, where they're kind of the stepchild, right? Especially the more rural you get. The OEMs, the ISOs tend to say, well, I'm going to focus in on the major metropolitan areas first, and then I'll go out and take care of this hospital. And the question I have about that is why? In my career, I've served rural hospitals off and on, but again, in the last couple of years, it's been much more so focused. But in those experiences, even in the past, I've always placed an emphasis on those rural hospitals because they, unlike the big medical centers, don't have the redundancy, right? They have one portable, right, that they use throughout their small little facility, but that one portable, if it's down, is critical. Where they have 6 rooms, so one monitor out of those 6 rooms can be much more critical than a major academic center with 500 beds and 12 portables, right? So here's some wins that we can build on, though, from a right to repair standpoint. We all know, hopefully, we all know that John Deere signed a letter of agreement, basically, with the Farm Bureau. There is legislation in many states, including my home state in Nebraska, that's passed where farmers can service their own tractors, right? Or they can have somebody else service their tractors. Those tractors are sometimes $500,000, right? Which surprises me. But they're expensive, right? These heavy machines are very, very expensive. And yet, we in our industry are not able to service a $500,000 heavy iron piece of imaging equipment because we are restricted in some way. But we're going to get a little bit more into that. I brought up some of the Massachusetts legislation and looking at this, just make sure I have it. And the EU. If we could follow up the EU a little bit better, the EU actually has specific medical device repair legislation that helps support patients ultimately. So I want to hear from you. In 10 words or less, if somebody can raise their hand though, not just scream it out. What's your worst right to repair kind of example or story?
I just got an email from folks at Fresenius that showed they got an email from Mesa Labs that says nobody's allowed to work on here except for them. And they will wait all their warranties on all their equipment. They continue to use us as a certification. They actually named us because they found out that the whole was cute. They were sending us their equipment to recalibrate because it was taking them 90 days to get it back. And then they would be in violation of not having their dialysis machines done on time.
So it was Fresenius or Mesa? Mesa, I'm familiar, they have the dialysis meters,
Yeah,
right?
the 90 XL.
Yeah.
We recertified. It's not a metrology lab. We recertified it, okay? And then all of a sudden they can't send it to us anymore, or they'll lose their warranty. Well, their warranty on all the other their equipment. So,
But can you service them?
they
I mean, it sounds like you have.
we were set up to do it. We've been doing it for almost 2 years with it.
Do you put patients at risk? And this is not exactly medical equipment, but it's the test equipment to support
The
them.
dialysis machines it's a violation if they don't have those machines done on time.
Yes,
So
yeah.
they can't put it on the floor. It's not going to be certified. So
But you feel your company
we're not
is capable of doing it?
Yeah.
Are you accountable in doing it? Well, who are you accountable to?
We're accountable to ultimately the patient. Okay, we know that what we're doing is the machine is certified. We have the equipment to certify it, and we have our equipment to be certified by the manufacturer of the equipment to certify their equipment.
Now, the reason I ask about accountability is because there's an argument, and I get involved in these arguments every once in a while of, can I fix it, right? Or can somebody like Dave Scott fix it, right? Maybe it's not my specialty, but can Dave Scott fix it? And then there's the question of, is Dave accountable? And I have the privilege of working with Dave, and I believe he's very accountable in the work that he does, right? He's responsible and accountable for the work he does. But there's a second level, at least, of accountability. I'm not sure it's the patient. I mean, I know that this audience primarily is thinking, we serve the patient ultimately, right? Sure, we make the lives of nurses a lot easier because the equipment's up and available. We make our CFO look, we'll stop breathing down our neck because, well, at least things are up and running so we can perform imaging and diagnostic procedures. But I'm going to talk a little bit about that accountability when we talk about things that our profession might want to consider doing.
Another form of accountability is on the companies that are pro-biomed. We go to the factory and we get trained. We got trained on the CABI IV pumps during COVID when the whole place was shut down, and they let us come in because we got to pay to be there. Okay, and so and then you get the proper code so that you can get to the software and everything. See, just like the old Sigma pumps, you had to have that key to calibrate them. We went to their class, got trained by them. That's accountability.
Right.
The manufacturer's now endorsing you because you went to their class.
Right. There's that level of, you have a line of sight to how you were trained, educated, you're competent, right? Whatever that, it might be a certificate and later you develop even better skills after the class, but you develop a level of competency where you're authorized or whatever.
When you say accountability, would you be accountable maybe to whoever hired you and maybe their legal department? Because they're the one that might be the one that's facing legal action by the patient or whoever the end user is of that equipment. Is that what maybe be accountable to them?
Yeah. It's hard for a patient, and this is, and thank you for bringing this up. It's hard for a patient to identify that, I don't want to think about it, Dave Scott worked on that equipment. But they do know, Dave, you're working at UC Health. They do know that UC Health, during some course of action at UC Health, they experienced something that they think is was harmful, right? Hurt them in some way, or delayed their care, or whatever, and they've got a complaint at the very least. But let's talk about the hurt. The accountability, yes, for most technicians and the independent contractors and the multi-vendor service organizations comes into play sometimes through the legal department, the risk department, because those are usually the people that are notified first, either internally or because an external complaint comes in, right? I don't know why you didn't catch this, but I got burned when I was at the hospital. Nobody said this, but I'm looking at my wound and it looks like it was burnt. So that's what I'm talking about. It's hard, and yes, we are accountable. We are responsible for that continuum of care, but we are going to be held more accountable by probably the legal department. Or if you're an ISO, your legal department at the ISO or your CEO or whoever. In some cases, though, keep this in mind, you can be directly sued, even if the healthcare system says they will take care of you, right? And usually those are cases where you have done something completely negligent or intentional, right? Now, I should point this out before we get too far into that part of it. The FDA, ECRI was involved in this. I wasn't with ECRI at the time. And several other folks aggregated a bunch of data. The FDA looked at that data and they said, you know what? It doesn't look like there's a significant risk or even a real risk to be concerned with of who services the equipment. We all know of examples where a manufacturer has serviced a piece of equipment and that hasn't gone well, or the service procedure that the manufacturer's technician used wasn't adequate. One good example is years ago, there was a nuke med camera that was being serviced by the manufacturer. And unfortunately, there was an oversight. They didn't have an inspection of bolts, and those bolts failed, and it crushed the patient and killed the patient. It can happen to anyone, but it happens so less that it wasn't an issue, but there's negligible difference between whether or not it was an OEM concern, an ISO concern, or an in-house concern. But a lot of people diminish that and say, well, then why shouldn't we just fix medical equipment and be fine to fix medical equipment? And again, I'm going to argue a little bit with you all that I think the profession that services medical equipment, the larger profession, right, including the OEM service reps, possibly, we need to have a standard. We really need to have some level of standards, because it's not acceptable that a few people die, right? It's not acceptable, in my opinion, that one person died, right, or got harmed. Yes.
Most of our customers require every year a certificate from our insurance company showing that we have the liability insurance, so that to avoid getting into trouble, like you decide if something goes wrong, they want to know that we are going to be accountable in that manner, that we're going to have $5 million policy that is out there.
Yeah, but then that's a payout. Again,
I
mean, altruistically,
they won't
wouldn't it be
hire us.
nice if we could just
They won't hire
not-
us if we don't have to.
Well, yes, they won't hire you.
Right.
But if we could protect every patient, if we could play our role, just like nurses strive for this, just like doctors strive for this, if biomeds, the people that lead the biomed technicians, and I say biomeds, by the way, not to offend anybody, but it includes imaging service engineers and sterilizer engineers, but the people that work on medical equipment. If we had that same focus, which I believe we do in some organizations, but we have the standards, right? So going back to your comment, what's one thing that could have, it might not be in this, prevented this dispute, I guess, with Mesa claiming that you were not authorized to calibrate their test equipment?
Well, I think I explained that when the customer is no longer getting the service they need, because when they send it to Mesa, it takes them 3 months to get it back. And so they're not able to do their job by testing the analysis machine.
Well, I get that, but what could have prevented that? Is there anything that you can think of as a solution? Like, could you have been more transparent with Mesa and said, is there, I mean, could you have even talked to, maybe it wasn't a prevention method, but did you talk to Mesa after that and say, hey, why? Is there some way we can work with you and be an authorized extension?
We tried, and
Okay.
their legal department said nobody else is to do this, only them.
Okay. And that might not have been the best example, but let's move on. But look for ways that you can prevent these conversations or these questions from your legal department, from your patients, from the manufacturers, from another hospital system down the street of like, how are you doing this? Right? And are you qualified to do that? Yes.
We talked earlier about potential solution. How many in the group that work for hospitals are members of GPO, like Premier, Vizian?
And Al, if I might say, since some of you are third parties, let's make the assumption that your hospitals that you serve probably have a GPO or a GPO-like organization.
Right. So my point in that is that's a prevention method to get out in front of that. I think the organizations that I worked in, we created purchasing and service agreements that were negotiated up front. And it was made clear to every one of our vendors, our model for service is we do it, okay? If you want to do business with us, this is how we do it. You will provide all of the parts that we need. You will provide all of the training that we need, same as the training that your engineers get. You will provide all of the service keys that we need, same as your engineers get, or we won't do business with you. That's why I asked the question.
When do you see that in the GPO contract, though?
Was that,
When do you see that in the GPO contract?
I haven't seen it in a GPO contract, but my point is that I think we should move in that direction. The organizations that I worked in were large enough that we could leverage that power. I mean, one organization, our health system covered most of the state. So if there was a particular vendor that didn't want to play, they pretty much gave up sales for the entire state of Wisconsin. Most people aren't going to be willing to do that. One did. They learned the hard way, and a couple of years later came back and said, please, can we start doing business again? And then the answer was, as long as you comply with our way of doing business, sure. Okay, but I think that's a path. Again, talking about prevention, getting out in front of that, I would suggest making really good friends with your supply chain and your GPO to see if they would advocate for you in that regard.
And a couple of things, we were talking about this coincidentally a while ago this morning. And some takeaways that I take away is, Al has said, large healthcare organizations have a little bit more leverage. Typically, GPOs serve whoever signs up for the GPO service. So it can be that small standalone children's hospital that I used to work, right? They have a GPO. And it's one of the major GPO organizations. If that GPO advocated, say, for if it's the same as whatever UC Health, right? If it's the same, then at that level, it might have a more clear conversation right up front with these are the expectations of the healthcare organization, discounts, and in this case, really the service options that they have available. But the other thing I took away from this was, it's not all about the manuals. Al mentioned training. We'll get the right training, right? And I say the right training, but we'll have access to your training just like your engineers, right? It's one thing to say, crack open the book and try and figure it out. We've all done that, probably. Another thing to say, am I trained somehow? Am I really, truly confident? Did I read a book well? This is a hands-on career for the most part, at least the people that are servicing medical. Dave?
I feel like the Department of Defense does a good job at, getting all that stuff up front. Is there any lessons that maybe we can learn as the civilian side from DoD?
The DoD on some purchases, and so does the Department of Veterans Affairs, some purchases, they will spell out in their language what is expected with the delivery of any medical equipment, and they'll even sometimes go as far as what's expected in an ongoing kind of process, like so many, we expect that you have the availability to send our technicians to training or bring the training to us. So yeah, there's some lessons learned and learned from them. I absolutely believe you can. Now, I think I'll bring it up as like, it's an umbrella kind of GPO, right? So, but to pick on UC Health, since you guys are right there. UC Health could, if you don't already have this language in there, you could have something in there that's as simple as, and we've talked about this since I've been in the industry, and some of you have been around longer than me, is having the right language in your purchasing contracts that says these are the deliverables, right? And some of the better language that I saw was inclusive language about we will expect 2 copies. This is when hard copies were more prominent. 2 copies of the service manual, schematics, technical bulletins, and anything related to the installation and testing and servicing of that equipment, right? Because if you ask just for the service manual, you may get their version of a service manual, and it might not be the schematics, right? And you might need them. Less people need schematics lately, but they're still.
Well, you do want to be quite explicit about it. To my point that if you use a language that states the same information that your engineers are given,
Right. Chris.
And then I would throw in on that training, that verbiage is really important for these dates and timelines, because kind of feel the room here if anyone else has dealt with this, but we've had OEMs promise that training. And then next thing you know, oh, well, we're booked for the next year and a half just getting our techs trained. So we don't have the slot for your techs, but we can still provide you that third-party service. So we ended up coming to this agreement thinking that our techs were going to train. And a year and a half later, we're still paying them a la carte to get our stuff serviced, and our techs are waiting for their chance to go and get trained.
Yeah, and then
That's burned us. So, and that's all the expensive and the high acuity stuff.
that's a really good point. I have never myself thought about that. The training will be available within the year, right, or something like that. I don't know what can you share what you.
Yeah, exactly. I mean, it's like, then the warranty drops, and then you're paying them, you know.
Well, it may not be sneaky. It's not. Hopefully, I would say honor the app, right? Whoever you're talking about, and we're not talking about a particular
This is
company here,
multiple. This is a lot.
or companies.
Yeah.
But one would hope that they didn't have the intention of doing that. They just had a lot of new engineers that needed to be trained, or engineers that needed to be trained on new technology and didn't offer enough classes, right? They have their limits too, but I like and you'll have that in there. You force it at the front with sales to say, we will commit to this. First of all, we'll have somebody trained before the warranty comes off, 9 months before, or 3 months before, whatever that phasing is. You could get very specific. But you will have that slot available for our and not just the slot. Yeah, I get, because you say the slot, and they go, well, the slot was available, but it's assigned to somebody else.
Yeah. And a non-compete too, because we've trained a couple of techs for the OEMs before. That's.
Well, yeah, we won't talk about the non-compete. Let's talk about the competency of those folks. If they block, that's a whole, we can talk about that as well some other time. There's kind of a balancing act between the pros and cons of licensing. I'm going to switch over to licensing. And the reason I'm going to switch over to licensing is it's one element, possibly, that keeps getting brought up, but then it fizzles or it dies, or there's not enough momentum, and there's a variety of different ways. But it's only one element of what we can do as a profession to call it professional. We can call ourselves professionals, but it might be an avenue to have an endorsement from state and federal recognition levels. But there's pros and cons to it. We're going to kind of talk about that. And it's only licensing. We can talk about a few other things maybe as time allows, but I bring this up as maybe something that also helps answer some other questions that we just talked about. Right to repair. Recognition. If you hopefully can read this, again, it's pretty light, but recognition is not everything, but it helps us establish a standard, right? All biomed, let's say apprentice biomeds, if you use the language of electricians, all apprentice biomeds must have X, Y, and Z. There's some benefits to employers when they say, oh, you're an apprentice biomed, I already know that you have so many hours of work under a journeyman, say to use that language, right? That can be translatable possibly from the electrical trades. You have a certain level of education, etc. There's a certain amount of, yes, it probably increases your salary potential, right? I don't know if you saw this, but transit engineers, locomotive engineers in New Jersey last night went on strike. There's a labor dispute between their salaries and apparently between what their counterparts are being paid from other districts or other states. But it has its potential. So if you're looking at it from a money perspective, it might actually increase your pay. Of course, if you're a manager in this room, it also might increase the pay that you have to give your techs, and you're going to have to figure out a way to justify this, right? There's legal recognition and professional status, right? There's this legal recognition of what you do, and there's also legal recognition of what you do, in those rare instances that are not ethical, or they hurt the general public, right? That's why we have electricians who are licensed. I can tell you, I don't know why barbers are licensed still to this day, but because I've had some bad haircuts, like the one I've got right now. But medical review boards are not the only place that a doctor might have to respond to. These guys have too good a joke about that, but anyway. But here's kind of the pros too. It's a balancing act. Is do we have access to the information that we need to support the equipment? It's well known, and I gave you some of those numbers about the HTM profession, but it's well known that there are not enough field engineers or OEM engineers to provide all the services on medical equipment and healthcare. It takes a village, right? It takes all of us. It takes those great engineers from GE, Philips, Mindray, whoever, that wear that logo and they work on that equipment. And it takes the great ones that work on 50 different makes and models and 12 different device types in the hospital, from infusion pumps to ventilators. But there's not enough people, and there's a workforce shortage coming up even more and more prominently. There's not enough people to do the work. So why is it that we're not working together, right, with our manufacturers and et cetera? Now, I will say one of the things that people get concerned about, I get concerned about this, is how do we acknowledge that there are all these people in this room that could claim, at least, that they're pretty confident, right, by some measure. And hopefully none of you have been directly involved in harming a patient or indirectly through servicing. But let's say the competency standard is, I've worked in this field for a long time. I've been successful on my repairs and my PMs by these measures. If we were to ever talk about licensing, we need to talk about grandfathering, and we also need to talk about portability, right? David, do you still go to Kansas sometimes or other states?
Someone took over.
Okay. Well, to use that general example, a lot of field-based engineers, whether or not you're working for the OEM, whether or not you're working for the hospital system directly, or you're an independent service organization, travel state line. At East, it's even much more likely, right? But you're in the travel state line. I live in Omaha. Council Bluffs is like 20 minutes, right? That's Iowa, right? And Omaha, Nebraska, not Omaha. Some people confuse it with Oklahoma.
California's got a lot of rules. They want MVS.
Well, I'm talking about
MVS on everything vehicle, and it's like,
yeah. Now I'm talking about like the states cooperating with one another. And I moved from Utah. I was there for a long time, to Colorado, and then I'm in Nebraska. I'd like to be able to start my next job, which I have, the next day, even when my car was stolen. I don't know. I'll tell you guys about that story sometime. So I want to tell you that it takes a while to really think about licensing. This is a good example of a profession we well know, and that's nursing. Nursing, it took about 100 years to get to the point that we're at today. And it really took about 20 some odd years for all 48 states. And yes, it was only 48 states then, right? But for all 48 states to require some sort of nursing license. It takes a while to do this because it's not just a snap your fingers and you do it. And I bring this up because I have sat on the fence for many, many years about whether or not licensing is a good thing for our profession. I believe that it still needs to be well thought out. I believe that if the profession says it's not for us, for a variety of reasons, and that's the thing, but it also is something that it takes a while to get to these points. Here's where portability or a compact between most states occurred. And this is the same model as like a field service engineer would be in. It's more like emergency, airmed, life flight, those kind of examples typically. Ambulance services where a nurse may need to travel across state lines. So I want to bring up that we are kind of at this phase that a lot of organizations, they train their staff either in a hospital or a third party setting or whatever. And if we look at the path to go to professional licensing, we need to think more in the terms of not just training, but competency, right? Testing. Like a little bit, but testing, evaluations, that's what I wanted to say, of how competent people are to perform the work. Now, I mentioned electricians a slide or two before, and I'll say this to this group. How many of you have worked on the electrical in your own home? Okay. How many of you know at least that there might be some limits on what you can do in your own home and where you're supposed to hire somebody that's licensed? Okay. We'll leave it at that. I'm not going to ask, like, did you actually hire them? Right? But there's a reason, again, that it was thought, at least, that electricians should be licensed. And it was safety, right? There are some of us that think we can do things well. I can tell you, and every once in a while I regret opening something up and I go, oh, yeah, this is pretty difficult, because there was probably a pretty handy person living there for years, but they did some things that aren't up to code or whatever, that the surveyor, when they inspected the house, wouldn't have seen them. But I recently pulled out, we got a new oven, double oven. I'm like, there's not a box here, there's not Romex, and I should have known that. Took a couple more days to get it all done the right way. And yeah, I did all of it on my own, and I had an electrician friend of mine certified, right? But there are avenues. And the reason why is because that handy person, had I not seen that, someday down the road, it's possible we would have had a fire behind that wall, right? It would have been safety for me, the new purchaser of that. Which gets me to something that might be a little controversial for most of us. I hope it is a little bit. And that's the thought of, what does right to repair really mean? Right to repair, when we give the automotive example, we think of this as, most of us probably in this room think of it as, we can work on our own car. We can work on our buddy's car. We can get the information to service most things, and we can get most of the tools. Some of the tools are now harder to get unless you want to pay $400 or $500, right, to get them, and sometimes you can't even get that. But for the most part, you're working on either somebody else's stuff or your stuff, and you're doing it all. And remember I mentioned the safety factor? I see it as there's two classifications of medical equipment. There's the stuff that I have, like I have a CPAP. If I mess that up, I have really low sleep apnea, but I could die, right? I could catch fire, whatever. And I put myself at risk. Possibly my wife, if she doesn't hear the fire, right, or smell the fire. But when we work on medical equipment that supports somebody else, is that where we draw a line, right? Would it be appropriate to say that that's the same case where if I'm working on a ventilator, should I have accountability, where we kind of started with, should I have competency some sort of demonstrated competency in case there's a question about how are you qualified to do this. And ultimately, should I have some sort of professional credential that says, yeah, it's generally okay. And the reason why licensing might be around for the profession is honestly, it does happen from time to time where somebody does something that is, well, let's just put out the most common example that I've seen in my history, unfortunately. And this is OEMs, okay? This is ISO, and this is in-house techs. They take a shortcut. They pencil it, right? They don't actually do the PM, right? Now, if that's an intentional, right? There are situations where I've forgotten to take off the one tag and I put another tag on, and then one of the other techs jokes at me. He's like, hey, I saw that in the Holland. You know there's a tag on the other side of that, right? That's just me being a little lazy on the physical inspection or taking out the tag or whatever. But if I don't do the procedures that the OEM or the hospital that I work for has established are the procedures that are intended to be done on that equipment. If I don't do any of them, I shortcut them, I change them around or whatever, I'm taking an active, intentional reasoning to do something wrong. Now, the downstream effect is it affects patient care. That's when I would want to go up to any of you. Well, I wouldn't want to be in this position, but if I was in this position, in a licensing perspective, if you were on the board, like Jonathan was on the board, Robert was on the board, I'd be hanging my head. But there's consequences, possibly there's a punishment. My license might be suspended. I may not be able to work. And as rare as that is, that happens where there's something that harms a patient. It's much more common, unfortunately, that there's some of us out there, and probably nobody here, right? But you've seen it, that just don't do the work, right? And those are the ones that are taking an intentional act. Right? I have never heard of a biomed sabotaging piece of equipment, so that would be another case. And I've never heard of a doctor death kind of scenario for biomeds. But I say this because there's that level of accountability to the profession, right? That could be part of license. Any questions on that or any comments on that? Or I know that's a little controversial, but we can hold ourselves accountable. We can hold our teams responsible and accountable for doing the actions. But ultimately, at the end of the day, if something does happen, might be a good thing to have a professional review board of what happened and making sure that that person is sees some sort of consequence. So I mentioned the electricians. I gave a little example that the models are different, but I usually have said to people somewhere between electrician and nurse is where I see the professions that are at least licensed. HVAC kind of came up too, because there are certain certifications that HVAC technicians must have to do certain things. If you've worked with those great biomeds, which I have, who have that HVAC certification and can take the refrigerant out of a cryotome legally, it's good to work with them. But I say that's because there's different methods, and if the profession, and I'm talking to the Colorado audience specifically because you all have progressed along the right to repair level quite a bit, and I'll mention a little bit about licensing or registration of some of your professionals in this field. Dave, you're still, I'm assuming, you're still registered with the state of Colorado to service. No?
I don't work on anything.
Oh, okay. Oh, he doesn't work on imaging equipment, but talking to the Colorado audience, but those of you that don't know this is Colorado or outside of Colorado. Colorado specifically requires a test to register to service imaging equipment for certain people. They split it around and stuff. Nebraska, I just have to say I read and I know where the code is, right? And I have to also demonstrate, what my competency is by certificates and your experience and a resume and that. But then it's much easier. And in Iowa, the service company has to be registered.
In Colorado, it's the company and then each technician.
Yeah. Nebraska is the company and then each technician. But Iowa is just the company. They can just send it over, right? And I say that because it's a starting point. Now, the reason why there's probably this credentialing is because somebody said it's radioactive or it produces radiation, right? It's a different set of rules in some way. They're trying to protect public safety again. But it's a small subset of what I said I call biomed. Imaging professionals have to do this. And there's all sorts of nuances. For example, in Nebraska, if you work for the hospital, you don't have to be registered. The hospital doesn't have to be registered to service their own equipment, and the technicians don't have to be individually registered. So I say that because it varies from state to state. It's up to the interpretation of the Department of Health usually and their radiation services, or it's a separate division in places. But Colorado's kind of ahead of the game because you have probably the best I've seen competency based. At least there's a test, but it's not too hard of a test.
That is on regulations.
Yeah, it's on regulations. It doesn't really show that you can work on equipment, but it shows that you know what the end result should be.
What paperwork to fill out.
Well, yeah, what paperwork is, yeah, but that you are responsible for protecting patients in a way is the underlying theme from radiation exposure, like dose limits, et cetera. So here's the big question on licensing. It's not cheap. There's not a lot of us, period. I should have said this somewhere near the beginning. I didn't, and I apologize. I'm not one for a lot of regulation. I think we have plenty of good regulations in place. I think in some cases, and I'm arguing for the fact that, or for the idea that there should be a meaningful conversation truly about licensing or professional standards of some type. But when it comes to licensing professionals, there are all sorts of administrative costs to doing that. There's the cost of the people handling the paperwork, right? All of us in the room, if we went and wanted to be licensed in the state of Colorado to do that work, would have to pay something to pay those people to administer the databases, whatever, right? There's the cost of doing business for the state. It's complicated too. It's not as cut and dry as I took a test and now I'm in the database. They have to check some sort of credentials and make sure that you're current. There might be retesting and those evaluations, or there might be continuing education requirements, right? A lot of professions have those built in. There's cost to the employer, certainly, because you're now probably going to ask them if your employer pays for, say, certification renewals right now. Think about this: if your whole shop, or your whole division, or your whole healthcare system, all the biomed techs now need to pay a licensing fee, they're going to ask for you as an employer to pay for it. Now, you have some options; you don't have to pay for it, right? But eventually, the trend is probably going to go to, just like nursing, just like the electricians, your healthcare system is likely to be paying for that license or the licensing fee. So there's a cost, keeps going up. But administratively, going back to the state, it has to be, usually in most states, it has to be a break even right? Can't cost the state anything. And I truly do believe that we pay enough in taxes on other things, even though it might be fractions and fractions and fractions of pennies that every taxpayer would have to pay to subsidize or to support an HTM professional license. When we talk about licensing, we talk about, is it the right thing to do? We've also got to talk about the practical things. You know, is it even practical? And I just mentioned hospitals. I did want to say this. I was going to use this opportunity in this presentation to say that Wayne represents a company that is doing, I believe, and this is not an endorsement from ECRI at all. I believe this from day one, doing everything right and for the right reasons, but really advocates for making sure the right people are doing the right job. That'd be a good way to say it, right? And Wayne's also in some other leadership positions advocating for that. It's not adversarial, I believe. It's complementary to what I believe. That when it comes down to it, we can't just necessarily expect all techs to do a quality job, wherever they come, right? Whatever shirt they wear is an example I keep bringing up. But we can expect most of us to be accountable ourselves. Is there a reason, maybe, to hold some accountability for some others? And when I'm talking about licensing, some of you may have thought about this, but I'm going to kind of bring it home. I mentioned right to repair. Right to repair, one of the biggest arguments about right to repair is how are those other people that aren't wearing the Philips or Mindray or GE or Siemens or whatever company, right? Covidien, Medtronic, I mentioned any manufacturer, possibly. I don't know all their opinions, but how are they qualified to do the work? And I'm going to get into that a little bit about qualifications, but there would be probably very little to debate if we said all servicers of medical equipment would have this standard met. Remember I mentioned that there was a high number of how many people are certified in the HTM industry alone, the percentage. It's really, and that number comes from 12,000, then you take what Amy says are actively certified, et cetera. But the point is, when it comes down to it, the question then gets down to how are we working together more than why are you telling me I can't fix my hospital stuff or my client's stuff? I'm very capable. I fix my own washing machine, despite my wife begging me and saying, "Don't you think it's time to get a new washer?" No, this one's fine. I got it. It cost me $100 for the part. I'm free on the labor, right? But it's not a good argument to say I'm good at doing something. I'm good with my hands. It's not as substantial an argument if the argument on the other side is we train all of our engineers before they do that first search. Now, I know that's not always the case. I've worked for OEMs. And sometimes there's a different model, but the ones that I've worked for directly, they don't send you out and start having you do work on something you're unfamiliar with. You're shadowing, or you're trained and then you're shadowing, but there's a method, right? It's hard for us because UCL's doing something different. Rocky Mountain Biomed's going to do something different. You're going to have a different training model. You're going to have a different training model. You're going to have a different training model than everybody else. And then how do you tell, more consolidated group? Philips has a different training model than GE does. It's like, from what I know. But when it comes to imaging engineers, they go through, what's your baseline understanding? You don't understand this, we're going to train you on this, then we're going to give you model specific training. But remember, there's a cost. licensing is not something that we should enter into lightly because it might be impractical. So moving across state lines, I already kind of mentioned this, but states need to maintain their sovereignty. I believe that it's the United States of America, right? We can debate that a little bit offline, but usually licensing starts with states. There's very, very few professions that are recognized at a federal level. There might be some variation in how the states would license individuals, like I mentioned, with the registration. I'll call it registration of servicing imaging equipment across different states, but there's a baseline, right, in the sense that it is a professional license. It may allow then to kind of acknowledge that there are people that remotely service equipment, right? You want somebody remotely servicing your equipment that you don't know who they are, and I shouldn't say you don't know who they are, but how they're qualified. And gives you that response flexibility, right? And that's, again, in licensing. Right now, I can go anywhere I want, mostly, with the exception of imaging, and specifically radiographic imaging, right? So, I mentioned it takes time, and a practical path forward is year one, we talk about it. Whatever that year one is, it keeps getting pushed down the road, but we really have a talk about it. We don't just, select a few people that are thought leaders or our buddies and whatever, but really open it up and make sure that we include a lot of different opinions, right? People that can say, oh, did you think about this? Or I totally oppose that. So you know what the counterpoints are. Year two, typically, this is with any law or most licensing that I've seen. I've been following this for quite a while. Usually it's 5 to 10 states, right? Hey, it's really that first one that gets out there, the head of the game, and then a couple more. It doesn't happen to the other ones. I'm from Utah. I can tell you Utah was a late adopter on a lot of things, right? They waited for other states like Colorado, for example, to take the risk. But those 5 to 10, it's an opportunity to kind of say, well, was that well thought out? Even after we had all those discussions. And then phase 3 is, the interstate contacts, the specifics, all of one. Now, in the presentation, I said I talk about certification. I'm not going to talk just about AAMI certifications, but those are the core ones that most of us think about when you say certification. Certification is not the same as licensing. It's a testament to you passed a test, right, at a particular time, or you might renew it or whatever. I happen to have a few certifications myself, but it's not a license. So take those two things separate. Very few of us are certified. I've worked with some of the best people in my life that are not certified, and I've worked with a few that are certified, and I would not hand them a screwdriver. Right? I have, because I've worked with them. You got to work with people you get assigned to work with. But if I had my preferences, okay. Few of us have more than one. These are the key certifications. And then, of course, if you don't know about this, but there's a new word. It's been around for about 5 years or so. CBET. These are some averages. Usually there's a pay bump, maybe a bonus once you've achieved it. But one of the things I want to point out is your ROI. Even if you pay for these things out of your pocket and you say do get a bonus or you get a raise, you pay for the test. Typically, your return on investment, if it's an outlay of your own money, is 6 to 12 months. If your organization or the organization you want to work for, maybe, is going to give you some sort of bump. Not Every place gives 5%, maybe it's 8%, maybe it's 3%, maybe it's $5. But your ROI in about 12 months on average, 6 to 12 months is there. You're starting to make money after that.
Gives you an extra day of PTO.
If they give you an extra day of PTO?
Yeah.
But that's a whole other thing, but I will tell you, I calculate PTO as how many hours I had to work to get that PTO and what my hourly pay is. And I go, well, let's say I make $10 an hour. I haven't made $10 an hour in a long time, but I did as a biomed at one point. Make $10 an hour. If it took me 80 hours to earn, or let's say 8 hours to earn 1 hour PTO, get a day off for $640. Right? 8 times 10, or yeah, 8 times $10 an hour for every hour I earn times 8 hours. So it's valuable. I guess you'd have it. At that point, you'd be very close to starting to, especially if you got 1 day extra a year off, if that's the value. But I wanted to bring up, there are other certifications, and these are just a few that I could put down. The slide could have been even more busy. But remember, there's project management certifications, there's ITIL certifications, there's, I don't even think I have the ITIL, I have the cybersecurity and compliance related certifications up there. The vendor programs I consider a certification. They're usually a certificate, right? And they might have a test or might not. But all of these are just a snapshot of the certifications that HTM professionals might want to consider adding to test their knowledge and to demonstrate their knowledge along their career. Now, as my first civilian boss said to me once, and I think he's absolutely right, is everything is related to being a biomed. Every bit of education or experience you can gain usually can be applied somewhere to biomed. How many of you have watched this is not a good example necessarily, but watched a movie, watched a TV show and gone, why are they using that? Right? That's not even the right, I do it, like that's not even from the right decade, right? That defib that was recalled by the FDA, you know. But I say this because CBET, CRES, CLES are not the only certifications that demonstrate your competency in certain areas. And then I'm pushing the pointer, but I will say that there's combinations of these that you might want to think about. And I'm illustrating a couple of these because those combinations sometimes might tell a better picture of what you want to do or what you are doing. Say you're a quality engineer, you're a network specialist, right? You're a cybersecurity medical device specialist. CBET, for example, how many of you have taken the CBET at one point or another? Okay. How many of you felt, even if you took it recently, that the CBET covered enough of the IT-related concepts that you might need, that you might encounter in your job? Okay, I don't see any hands raised. That's probably very true. You can only cover so much in those 165 questions. 165. Dave's the expert. He talks about this all the time. So the last thing I want to mention is where these all kind of come together. I mentioned that licensing supports that competency, right? That competency discussion that comes up too regularly on right to repair. Is the OEM actually competent to do this, right? Or is the in-house engineer not competent to do it? Those debates kind of start getting less and less, right? With something that holds a standard, right? And it could have been certification, but as you just all kind of acknowledged, and I kind of got this, is that one certification, for example, the CBET, doesn't cover all that you might need to know, right? And it definitely doesn't cover, say, the specifics of a modality, right? CRES, the narrower thing, but it's a little bit more specialized, but it still doesn't cover it doesn't cover every modality when I say. And certification, it does help standardize, right? Have those conversations with your vendors and say, hey, I have a certified tech. Does that make a difference between you giving me the service manual or not? And if they're telling you,
I
no,
hate to
well, we should
interrupt.
go.
We're
Yeah,
we're
sorry.
10 minutes over.
Yeah.
I gotta wrap up for the next one.
That's it.
Oh,
Yeah, I had a couple other things, but yeah, thank you.